keynote for today, Dr. David Barzilai. I'm going to take a quick second to introduce him because I do have a wonderful introduction. He is a distinguished physician and a longevity consultant with excellent and extensive academic background. As a diplomat of the American Board of Lifestyle Medicine, he brings a wealth of knowledge to his role as a founder and CEO of HealthSpan Coaching. Through his platform, agingdoc.com, Dr. Barzilai offers personalized and one-on-one coaching, integrating cutting-edge science and technology to empower individuals in their pursuit of healthier and longer lives. His commitment to evidence-based practices and individualized care positions him as a leading figure in the field of longevity and health optimization. Please welcome me in greeting Dr. David Barzilai to our stage.
So where do I begin after an introduction like that? Good morning, everyone, ladies and gentlemen. I'm so excited to be here with you today. What an honor and privilege to be asked to be keynote for Canada's first Precision Health and Longevity Summit, the beginning of a long tradition. And what a beautiful way we started this morning. An indigenous prayer, which to me reminds me of why we're all here. And I think that's something we'll be reminding ourselves of throughout our entire lovely day together. What makes humanity humanity? I think it's our humanism. And this is something that we see in these holistic indigenous cultures, that in this era of modernity, we're innovating, but in some areas we could be remembering our roots. We came from a species that took care of its elders and respected them, and took care of our young, and look after each other. Within our tribe, which I interpret as our global tribe, every man, woman, and child on earth, we look out for each other, and we innovate, right? We're compassionate, humanistic, but we also innovate to try to create a better world. And what more fundamental representation of us as a species, how we see ourselves, and how we view what it means to be part of our tribe, which should be everyone, and ensuring that we all have a good life. HealthSpan is foundational to that. So a sort of recap of that introduction, because it's the lens through which I look at this presentation I'll be delivering. So I'm a longevity physician and consultant. I apply best practices in longevity from lifestyle medicine like exercise and diet to the cutting edge biomedical innovation, even things that are preclinical and animal models, thinking about a precision approach to considering those, weighing those at the individual level. I look at that through the lens of PhD in health services research, and also through the lens as a doctor and someone who tries to be a bridge between aging biology at the fundamental innovation side to applying it to the bedside, because none of this means anything if we can't work with stakeholders and government and work together. And that's what this meeting is all about, right? We're all from different sectors. So as I go through these slides, I try to give a little bit of an overview of the landscape to remind us why we're all here, and as everyone's speaking, thinking where that fits, and when we come home, how are we going to apply that to the work we do, the wonderful work we do, making the world a better place. That's my QR code over there. I'm trying out the pointer for the first time, or this. Hopefully will advance. If you want to connect with me on LinkedIn, this QR code will appear at the last slide too. You look at a photo, click on the link, and I'm happy to continue the dialogue, whether it's artificial intelligence and devices, or aging biology or aging biotech, the whole landscape. So without further ado, we have testing out the pointer here. And this is a web-based pointer. Oh, is there a delay? You guys doing that?
This side.
Oh, okay. You know, literally about half hour of the morning was trying to figure out how to troubleshoot, and I was like, if I don't have slides, it'll be fine. And so we're going to wing this, okay? But we'll have fun. So let's remember the problem. The problem is And it's an opportunity too for all of us in government, as entrepreneurs, as clinicians, is we have an aging demographic. We're getting older, not just at the individual level, but at a societal level. We're going to see a doubling from about 1 billion to 2 billion individuals over the age of 65 between now and 2050. The proportion over 60 will nearly double also. And with that, we're going to see a big change, and that's what we're going to talk about to begin. These advances in medical technology, in fact, most of it's been sanitation, public health, immunization, ways that society has addressed the sort of public health roots of disease. That's what's led to this expansion in our lifespan. But this expansion in our lifespan, this extending of our lifespan, means we're all expecting to live to years where our bodies naturally, through the biology of aging, tend to decline. So that presents economic challenges, it presents challenges in how we age properly. And my vision is, let's make this not about sick care, let's make this about health care. Let's not make this about sick span, let's make this about health span. So how are we going to do that? This is just a little picture about what's happening. So on the left, we see the fraction of the world over 65 by density by country. So from 2015 to 2050, that's what's going to happen. So literally, we have a gray tsunami that's coming that we need to prepare for and leverage towards better care. Whoa, that's unexpected. Should I point it to you guys?
Yes.
Maybe I need to point it that way.
Yeah.
You know, it's like finding your car in the garage. There's a delay too, so I do it once and I wait. See, a lot of innovation is trial and error. Keep your eye on the prize, you'll figure it out. Okay, so societal implications of aging we discussed. This is going to have implications on our pension system. It's going to have implications on the workforce. We're going to have longer careers. We might have several careers. My most recent career, I started at age 49. Now I'm taking on more an entrepreneurial role and someone bridging different ecosystems to drive forward innovation and change from industry to government. So maybe if I look at this one, I can face this way. Let's see. So this shows us how much we spend on a population based on their ages, 0 to 18, 19 to 24. So you see there's a more than linear, even an exponential growth in how much is spent for us as individuals as we get older. And that corresponds to the changes we undergo with aging now that we're not dying at 30 or 40 like our ancestors. What I want to introduce here is a concept that will be central. It's a concept of compression of morbidity. James Fries discussed this, and basically the aim is to reduce the period of time spent in poor health by delaying the disease onset or slowing it down. Currently, individuals in the United States spend about 35% or a third of their post-retirement life in poor health. And if we're getting older, as a population, this is only going to increase unless we do something about it. So it's essential to our personal well-being as well as sustainability on our economic system and on all of us and our families. This is just another way of looking at it. You know, we say we're living older, but our maximum lifespan is pretty unchanged or minimally changed since biblical times. What we see here is from 1950 to now and projecting to the future. The top shows how old we're living, some of us. The difference is that we're all living longer. And this is another representation. Don't be intimidated. So this is like a survival curve here. On the left side, looking today, and this is the vision we're talking about. We see the fraction alive at the y-axis, and the x-axis we have age. So the idea is we want to push forward, not just push forward the survival, the mortality, but we also want to move the whole curve down so that we're spending more time in good health to block it off. Ideally, we would have a full life and then not this extended period of poor health. So on the right, we see the concept of sick span versus health span. When we cure one disease at a time, typically what happens is lifespan is extended by a limited amount. Does anybody in the audience know if we had a complete cure for cancer today, by how much the average lifespan would increase? Does anybody want to guess? 3 years. We have a very educated audience here, which is wonderful. Why is that? That's because our whole body's biology is getting older. So if cancer doesn't get you, dementia is, you're going to get frail, you're going to fall. So we need to have some way of addressing that while also thinking at a public level, having access, equitability, and having a preventative-oriented landscape instead of one that waits till we get sick when it's already too late in the game. So longevity medicine is one avenue. It's something that I mentioned. I practice longevity medicine. So what is it? I want to define it with you a little bit and see how it fits in all of this. There isn't a single uniform definition, but focus on improving the length and quality of life. It creates personalized health plans to address chronic disease, but moreover, it's throughout the lifespan, right? Gerontology is the science of older adults. Geriatrics is the practice of older adults. When do we start to age? At birth, right? Or before that, right? There's epigenetics, right? How about what our grandparents ate? At least that far back. Yes, grandparents, not parents. That's a little complex. I'm not going to cover that with you today. It's another topic. So it's interdisciplinary, and it focuses on lifestyle medicine and precision medicine and innovation. So one definition I'll take from here. This just discusses the role of longevity education. Longevity medicine is advanced, personalized preventative medicine powered by deep biomarkers of aging and longevity, and it encompasses various areas that we discussed. Geroscience, which is aging biology, the fundamental what happens to our bodies. Precision, preventative, and functional medicine. So that's just one possible definition. So what are its aims? It should be proactive and personalized. We need to look at patients as individuals. There was a book, House of God, I read before I was in med school, and patients were described by numbers as opposed to by names. We have a stethoscope. We have these labs. We're not even looking at the patient. And so we need to take into account as much data we have, now that we have AI, to really understand what addresses this person's needs and get to know them so we know their values. What's important to them? What's important to them? There should be some discussion. We need to be not this top-down, solely expert-based. We'll always need experts, but we need them to guide us so we can live the most fulfilled, healthy lives that we can with all the advantages of modernity. So longevity medicine is centered on vibrant, active, meaningful lives. Okay, that worked. That could work. Precision medicine and emerging therapies. So precision medicine relates to what we were discussing about having things personalized. For example, ApoE carriers, where there are certain polymorphism or variants of genes. ApoE2, ApoE3, ApoE4, ApoE3 is the most common. If you have the ApoE4, your risk of developing dementia or Alzheimer's disease for a given age depends on the study, up to 3 to 5 times fold. And it's up to, if you have both alleles that are the bad kind, your risk for dementia is, some studies, up to 10, 20 fold. It's really dramatic. So knowing our genetic profile, such as through genomic sequencing, is an indispensable tool. So what might apply to one person, it might be their heart is the weak link. Maybe it's an Lp(a) variant. For someone else, it might be their brain. So Precision looks at all this data, including wearables, anything you can measure, and asks what makes most sense for someone. So that's a key component of precision medicine, which is one of the pillars of longevity medicine, as I envision how it should be practiced. People define it different ways, but I think we can take advantage of the whole landscape here. So how is preventative medicine, precision medicine, lifestyle medicine different than longevity medicine? Well, precision medicine, we just discussed, it tailors to all of this data longevity medicine is broader and encompasses that. Preventative medicine is part of longevity medicine. We're trying to prevent disease. We want pre-disease. Then we just discussed that dementia, the signs of that appear decades before you're diagnosed. So we want to intervene before we get there because it's a lot harder to undo the damage after the fact. Lifestyle medicine advocates for behavioral changes for health, but longevity medicine tries to look into technology that can actually slow or modify the aging process itself. The ultimate goal is not just prevention, but optimizing the process across life stages. So this is another way of looking at it, okay? So we see on the left of the slide here, there's a cloud with all your data, everything, from omics to maybe your wearables, your functional markers in a clinical office visit, and it's all integrated. On the right, that's lifestyle medicine. So what's lifestyle medicine? We all know what lifestyle medicine is. It's not about where you went for a cocktail party. Lifestyle medicine is about exercise, diet, sleep, stress, relationships, meaning and purpose, top of Maslow's pyramid, self-actualization and beyond. That's what that is. I'm very passionate as a diplomat of the American Board of Lifestyle Medicine, which is a physician certification in this area. But these things apply to everyone. I think every doctor needs to be trained in this. So if you can read the caption there. I would love if we had this magic pill, get rid of all doctors, magic pill, or connect ourselves to the ultimate AI. We're not yet fully taking advantage even of the AI we have now. I'm super excited about that. But we don't have a solution like this. Until we have a solution like this, lifestyle medicine will remain for, I would say, always the pillar of healthy longevity. It's not all this fancy, I cater towards affluent clients. It's a very tailored service. This should be accessible to everyone. The good news is the most important evidence-based and powerful tools are available to all of us. But we need to have uniform implementation across society, right? We want to take this to the doctor's office, have that discussion between them, coaches, consultants, have a real integrated delivery system. So let's talk about scaling lifestyle medicine, just for a sense of power. If we look at physical activity, not smoking, managing stress, healthy diet, moderate alcohol, good sleep, positive relationships, and avoiding opiates, at midlife, we're talking about a difference of 20 plus years for men and women of extended healthy lifespan if you're at the top versus the bottom. Just think about that. We don't have anything near that for any of our pharmaceuticals, as important as they are, saving millions and millions of lives. So this is something we are at the bottom of in terms of our potential. And there's actually, you can look up, there's a global roadmap for healthy longevity through the Institute of Medicine. There are different pioneering groups like the Evolution Foundation and others, and here we're talking about UAB, that are looking at integrating these. This is just another way of looking at it. Which curve do you want to be on? This is the number of lifestyle factors. And by the way, it's a good opportunity. It is seldom, in fact, this is the first time I complimented a conference for super healthy food. Whole foods, natural foods, minimally refined, processed, like from the farm, what our grandparents would recognize. Great conference. So aging biology and longevity medicine. So let's talk about that a little bit. I alluded to it, right? That there's a fundamental biology of aging. This is very interesting. I think this is something that is worth unpacking. If we can unravel the cellular and molecular pathways of aging, we can design more effective therapies for longevity. Let's unpack that. So until recently, the focus has been on individual diseases. There's the concept of the geroscience hypothesis. Remember when I mentioned if we cured cancer, it would extend average lifespan by only about 3 years or so? Excellent work by colleague Jay Olshansky. He is a health economist, a geroscientist, and was a real pioneer in this area. Talking about the longevity of a dividend. If we make people healthier, they'll be more productive for societies. They'll work longer. They're not just consumers, but they're starting whole companies. So the geroscience hypothesis is if we can get at the underlying cause of these problems, the way we age, then we can do much more than 3%. Just a small percentage of slowing the aging process, which, as we'll see, we've actually made progress on. We're making progress in animal models. We can substantially extend our healthy lifespan, as well as extend lifespan itself. That's because essentially by looking at the one core driver, you're affecting diabetes, you're affecting dementia, you're affecting stroke, heart disease, and so forth. So this was really groundbreaking. There's some of you have heard of, raise your hand if you've heard of Calico Labs. This is the Alphabet or Google, their top secret aging biology lab. And this is who they recruited. This brilliant woman who, together with Tom Johnson, found that before we thought aging was too complex for us to really, we're talking 20,000 genes, so much transcriptional regulation. There's no way we can modify this process of aging through a science approach. It's just too many interactions. What she found is in a worm, this was the first step, one single gene mutation doubled the lifespan of the worm. Like, one gene did that much? Their levers that powerful? Maybe we could do something about it. So then they started characterizing the pathways, like the insulin IGF-1 pathway in that case, or the mTOR pathway, another important pathway that's the target of rapamycin. Rapamycin, some of you've heard of. But rapamycin was the first pharmaceutical that was found to, in an animal organism, extend lifespan substantially. But it targeted this aging biology along the mTOR pathway, inhibiting it, and increased lifespan by 9% in males and 14% in females. That's maximum lifespan, even more for median. And that was just at that dose. Since that time, they found 25% greater lifespan extension. But this is the exciting part. These mice weren't just living longer. They had lush coat fur. They were like frisky. They were like active. They were acting like young mice. I mean, they were just like saying, can you imagine it's your lab? It's like we're giving this stuff to them. And look, they're mammal like us. And what's incredible is that the mTOR biology, there's this concept in biology of conservation, okay? So you say, well, that's a mouse. Who knows about human beings? This is what's interesting. Did you know that a significant fraction of what we found works in people has been exactly this pipeline from animal models? And for this particular one I discussed, we find mTOR in yeast. It extends their lifespan. We find it in Drosophila, Drosophila, a fly. C. elegans, a worm. And it's also found in mice. And it extends their life, all of their lives. All of these diverse, we're talking over 1 billion years of evolution. They have the same stuff in them, same essential regulator, okay? And we do too, and it makes them all live longer. So, it's an immunomodulator. It has some immunosuppressive, some immunostimulant effects. But we need to study this in people, right? And this is just the tip of the iceberg. So let's talk about, I'm good just for the sake of time. These are survival curves, and poof, the slide shows it works. These are some of the hallmarks of aging. These are the biological principles, which are biological mechanisms that is underneath geroscience. So what makes a hallmark a hallmark? That's moving from 9 to 12. They continue to change and not perfectly precise. But the idea is this: what makes something a hallmark of our aging, a target for us to try to intervene on, is that if you exacerbate that hallmark of aging, aging is accelerated. You develop all sorts of chronic diseases associated with aging, the model organism does. And it tracks with aging, obviously. It gets worse with aging. And most importantly, if you can intervene to make it better, then the organism lives longer and healthier. And we found that. That's what these hallmarks are centered around, whether it's in our epigenome, how it drifts over time from where it's an optimal set point, or genomic instability, how our genes have issues, mitochondrial dynamics, how they mitophagy, our power cell. Anyway, that's a whole other story, but they're signaling, they do signaling, they also produce energy, and they have this whole complex sort of replenishing process. So this is just a taste of the molecular mechanisms. I can give whole talks about just one hallmark, but the idea is they're there, we're targeting them, and that it's in model organisms it's working. For example, if you take SIRT6 from a longer-lived rodent and put that in a short-lived rodent that were like naked mole rats, they live much longer than ordinary mice, like multiple folds, then the mice live longer. This is actually another important slide to remember. What do we see at the bottom there? Exercise. So I think this is an important reminder. Instead of thinking about it, do we do lifestyle or do we do aging biology and other research, it's kind of both. The way exercise and nutrition work is because it modifies our biology of aging. When we look at the hallmarks of aging, they're all better. We just need to unravel this better. And when you work on one hallmark, it does multiple things. SASP, the senescence-associated secretory phenotype, produced by senescent, sometimes called zombie cells, a little bit of a misnomer, they're incredibly active. But they kind of release things that are harmful to tissue repair, and it also causes more cells to become senescent next to them. But if you remove senescent cells, you can address all of this, from heart failure, chronic obstructive Parkinson's, etc. Again, an animal model is something that needs to be tested in humans. And we'll touch more upon later about testing in humans, the challenges and opportunities there. And this is just another example, mitochondrial dynamics. You have mitophagy, you have mitochondrial biogenesis, you have new ones form, they fuse, they do fission. It's fascinating, and they're degraded. So evidence-based medicine is another important thing we should be thinking about. There should be evidence behind each one of our talks and everything in our whole field. Some areas are, thank you, some areas are flourishing, and some areas we're just at the tip of the iceberg. So for the sake of time, I'm going to be focusing on the most important slides. I want us to remember that evidence-based medicine is not a set of guidelines. We can't realistically have a randomized clinical trial for a lifetime on a human, right? Do you want to wait 40 years to see if it works? Do you want to randomize your kids at birth to intervention A versus intervention B? That ain't going to happen, right? So that's why one exciting area in our field of aging biology and geroscience, is biomarkers to look at indications when something's working or not. So when we talk about, we were just discussing at United Arab Emirates, a longevity clinic, and there are others, how do we measure whether something's working or not? That's part of precision care, right? We try something based on evidence, but then we also pay attention how it's working individually. We adjust, we steer. We have no pills to do this either. So risk mitigation is going to be an important part of this. So this means screening, aging biomarkers early. We need health surveillance. We need diagnostics. And there's a link between diagnostics and therapeutics, right? Each should guide the other and then back. As an example of the power of such interventions in longevity clinics, in this, for example, this was from Health Nucleus, they found that at baseline, 1.7% who had a rigorous screening, including whole body MRIs, 1.7% were found to have a treatable cancer, asymptomatic. That's when you cure it. You cure the cancer when you find it before symptoms. Sometimes you can after, but you're much better off early on. This is what we all should have, real-time data for all of us. They also found aneurysms that might be repaired. And come to me afterwards. You want to start a company in AI and longevity. It's an area of great enthusiasm, and I love interface with longevity clinics. It's something that I do myself, and I think collaborations with our field will make it stronger. But this is the whole idea that AI is not just helping us interpret data, but it's actively helping us design drugs, screen potential drugs, and build them from scratch. That's another whole set of lectures we could go through today. But best practices means it's ethical, it needs to be based on evidence, and based on what's a sound conversation that's unrushed about the risks, benefits, and alternatives, especially on less established protocols. It needs to be continuously updated. We all need to learn. We all need to be educated. That's why I'm passionate to be a trustee at the Geneva College of Longevity Science and faculty there, and as an entrepreneur. And it needs to be focused on patient education and all the stakeholders. We need to be educating the government, policy, because we all need to be working together to make this happen. And these are just some example. There's a Healthy Longevity Medicine Society talking about best practices in this field. I discussed the college, and we're just about to have at the Buck Institute the second annual roundtable of longevity clinics, and I'll be speaking at the Longevity Summit a couple of days before that, also at the Buck Institute. These are exciting times. These conferences didn't exist a few years ago. So looking ahead, how do we build a health span society as we close up? We want to have universal collaboration. We want to bridge gaps between these different sectors and all of us here. And we also want to focus on compression of morbidity through both the biology of it and the public health side of it, and on the innovation side. So we can only cover so much in a short talk. This was all the time we had. I would have loved to dive into not just these slides, but whole talks about wearables and so forth. But I would love to connect with you, and I'm happy to answer any questions. I'm at your service. Again, it's an honor, and thank you for having me as keynote today.